Welcome everybody, my name is Magali de Castro. I'm the Clinical Director at HotDoc, and in today's webinar we're going to be looking at top tips for accreditation. Now at HotDoc, obviously, we provide a whole range of solutions, but one of the things that we're very proud of is being able to offer clinics really valuable, relevant training and CPD, just to make life a little bit easier, because there's plenty of things going on in our day-to-day life in a general practice. So I myself have gone through accreditation multiple times. I've helped several clinics go through accreditation. I've written policy and procedure manuals from scratch, and I tell you what, that's a process that will teach you a lot. So if you ever get a chance to do that, highly recommend it. It'll only take away a couple of months of your life, but you'll learn a considerable amount. So the idea for today's webinar is, obviously, accreditation is one of those times where some practices tend to panic, or there can be a lot of stress associated with it, and there isn't really a need for that, because really it's an opportunity for us to look at quality improvement, how we could be doing things a little bit better, and yeah, so what I thought we'd do today is I'll walk you through some of the key things about accreditation, the process of accreditation. Specifically, we're going to look at the steps involved in the accreditation process. We'll also look at how to navigate the RACGP standards for general practice. I'll talk a little bit about the areas where there's common non-compliance when it comes to accreditation, and probably the most important thing are the resources that your practice can use to get ready for the accreditation. Now, this session is being recorded, and we always post in the HotDoc blog a week after we do the live webinar. There's going to be the post of this recording of this session, and on that recording there's also all the links and resources that I talk about today. You'll be able to access them and download them from there, as well as a CPD certificate for this session. So let's get started. Now, accreditation, this is a quote from the RACGP Standards for General Practice, the 4th edition, which is the current edition. So the process of accreditation shows patients that your practice is serious about providing, these are the key 3 things: high quality, safe, and effective care. So that's really the focus of anything that we do when it comes to accreditation. It's looking at our systems and procedures and making sure that the services that we're delivering are of high quality, that they're safe, and it's the most effective way to deliver that service. So more broadly, the process, when we talk about accreditation, what is it? The process itself is voluntary, so no clinic is forced to undergo accreditation. Having said that, even though it is a voluntary process, over 80% of practices in Australia undertake accreditation. The idea of accreditation is to make sure that practice services are in line with best available evidence, and that you're sort of abiding by peer-reviewed guidelines. The assessment that we do, so the standards, are actually based on the Royal Australian College of GPs, or RACGP Standards, and the current edition is the 4th edition. And it's a 3-year cycle. So once you become accredited, every 3 years you're going to have to undergo re-accreditation. So why go through this? What are some of the benefits of the accreditation process? Obviously, one of the things is to make sure that your policies and procedures in your clinic are actually in line with what's considered to be best practice. The other reason is because, obviously, by having these systems in place in that way, it helps protect your clinic, it helps protect your staff, and it also helps protect your patients, because remember, the focus tends to be on safety and high quality of services. It also provides an opportunity for the practice to stop and reflect on what are the current systems or the way that we're doing things, and explore areas where we might have a little bit of quality improvement. So you'll hear the term quality improvement a lot, and that's essentially areas where we could do things a little bit better. The process of accreditation also serves as a prompt to review, update, or upgrade equipment. I often joke that if there's any equipment in a clinic that you need, wait for accreditation time, and that's the best time to say we need it for accreditation. And somehow practice managers, and usually it's more to do with the practice owners, pockets open and things manifest miraculously around accreditation time, which I joke, but it is a good opportunity for us to reflect on, well, what equipment do we actually need to provide the best possible care for our patients. The other benefit is obviously that professional recognition with our peers. To obviously, by being an accredited practice, it means that we're practicing to a certain standard. The other benefit is the financial incentive. So by being an accredited practice, you get to access things like the PIPs, the Practice Incentive Programs, or the PNIP, which is a Practice Nurse Incentive Program, and also the SIPs, which are associated with the PIP, the Service Incentive Payments. So there are obviously some financial benefits as well that come from being accredited. Now, what are the steps in the process of accreditation? So if you're brand new to accreditation, the first step would actually be to register for accreditation with one of the two accreditation bodies. So we have GPA and AGPAL are the two bodies that can sort of provide the accreditation service. Then once you sign up for accreditation or register for accreditation, you get allocated a key contact person, usually with one of these two bodies, to assist you with some of the basic questions and some of the requirements that you're going to have to put together in order to successfully meet accreditation. Then the next component is usually what we call a self-assessment, and there's slight variations between the two companies, but sort of broadly speaking, they're relatively similar in that it's an opportunity to go through every single indicator and standard, and you do this in your own time, and it's usually done electronically to just make sure that yes, you definitely meet, and this is more like a self-check, you definitely meet every single standard and criterion. And then also some of the providers will also allow you to upload documents. So this might be, some of the documentation that they'll need to review. You can upload it beforehand, so it actually saves time when they come in and do the visit. Then the next step, usually a few months after the self-assessment questionnaire has been completed, the next step is the site visit or the survey visit, where you usually get 2 or more surveyors come to the clinic and go through different things. So with that accreditation survey visit, what tends to happen is you've got, as I said, usually 2 surveyors. One of them is usually a GP and the other one tends to be a practice manager. If you have a really large clinic where there's going to be a considerable amount of records that they might have to go through, then they might actually send additional surveyors. But for most clinics, it tends to be about 2. They also tend to spend about half a day, usually with the practice, so they might come in the morning around 9 o'clock, and then they'll be finishing up around 1 or 2 o'clock. So what those surveyors will do is they'll actually interview practice staff and ask them about, how do you do things in the clinic and about different, processes and systems. They'll also review your practice documentation, so your policies and procedures and things like that. And they'll also do an audit of your patient health records. This tends to be usually a random audit, so they'll just pull a random number of, or a certain number of health summaries or patient summaries to check that things are sort of up to date. And I'll talk a little bit in more detail about what they're looking for there. Then after all of that happens, the surveyors actually put a report together that goes back to the accrediting body. So they themselves are not the ones who accredit you or not. They just, they document what they observed and from the interviews and the visit of the practice. Put together a report, and then it's the accreditation body that then decides whether to grant accreditation based on the findings of the surveyors, or if there were areas of concern or areas where the practice didn't quite seem to be meeting the requirements, then there's a request usually issued for additional evidence of how you're either changing that or addressing that in order to be then deemed successfully to be sort of meeting the standards. As I said before, the current standards are the 4th edition of the RACGP Standards. These ones are going to be, the 5th edition is already in draft format. You can access it online if you want to have a sneak preview of it. It's during consultation stage, so at the moment they're open to feedback from stakeholders and clinicians about the the new standards. They're not expected to be released. They're expected to be released October 2017, so in a year's time. But at the moment, you can, if you want, have a sneak preview. And at the moment, even with the current standards, you can either access them in physical format, so you can actually order a physical copy from the RACGP, or you can access them online. Some clinics prefer to do get a physical copy, because then they can just highlight things and bookmark different areas to keep track of things that they need to still put together. But there's plenty of clinics that are quite happy to just go through the electronic version. In terms of the current standards, they're divided into 5 sections. This is going to change a little bit when it comes to the 5th edition, but we'll worry about that next year. So currently there's 5 sections, and these are around practice services, rights and needs of patients, safety, quality improvement and education, practice management, and then finally physical factors of the practice. So that's obviously relating to equipment and facilities. So how do we navigate the standards? If you haven't seen the standards before, obviously you've got your set of standards. Within the standards, you have different criterion, which is I've highlighted here, a sample of what that looks like. And that's sort of looking at more specific points. For example, one of the criterion is telephone and electronic communications with patients. You'll see that under each criterion, you have indicators. The indicators refer to how that component is going to be assessed, or what are the things that you need to be able to demonstrate to sort of be deemed to be kind of complying or meeting the standards. The indicators, there are some that have a triangle next to them, or what we used to call a flag, and there are some that don't have that triangle or flag. The ones that have the triangle means that they're required. So these are things that you have to have in place in order for your clinic to be deemed or to successfully gain accreditation. The ones that don't have it are recommended but not required. What that means is obviously, it's sort of considered best practice. It's a good idea to move towards those ones, and obviously the more of those that you have, the more commended you will be as a practice that's being very progressive and proactive. But yeah, the ones that don't have the triangle are not actually required in order to successfully attain an accredited status. So having said that, there's a lot of standards in the standards, and when the surveyors come to visit your practice, they can't possibly go through every single one of those indicators in detail. So they tend to just pick, kind of randomly a selection of areas to assess. Having said that, there are a set kind of key of areas that will always be looked at by your surveyors. These include the doctor's bag. So you obviously have to make sure that you've got at least one doctor's bag with obviously all the equipment that for emergency treatment of presentations and for adequate management, in general practice. The list of equipment that you need to have in that doctor's bag is all outlined as part of the standard. So it's actually fairly clear, all the individual instruments that need to be in that doctor's bag, as well as the recommended medications that should be accessible there. They'll also look at Schedule 8 drugs and their storage. This is only if you're actually using Schedule 8 drugs, so these are drugs of dependence, in your practice. Not if you're prescribing them for the patient to get from somewhere else, that's different. But this is if you're storing them at your clinic, they're going to want to see where you store them, because they need to be under safe. And they'll also going to want to see your records. What records are you keeping of doses given, which has to actually be quite specific, and in terms of the patient that it was given and all those details. But then also if things have expired, how you're documenting the disposal of those medications. Again, there's fairly specific guidelines within the standards about what's expected with those. Medical records, I will go into more detail about the medical records, but there will always be a component of usually the GP surveyor will go through your a random selection of medical records. It tends to be that usually, and this will vary from surveyor to surveyor, but what I've noticed the majority of the times is they'll usually pick any random day in the last couple of weeks, and they'll go, I want to see all the files from that day. So it's a good idea on the lead up to accreditation to start making sure that all those patient records are quite comprehensive, and I'll talk a little bit more about that in a second. The other thing that they'll always check is the doctor's RACGP, QA, and CPD points. Make sure that those are up to date, and their registrations. Again, have evidence that they're all up to date. The practice information sheet. So obviously this is the information sheet that you would offer to your patients. If you have a website, then again, they would be checking that the content in your website is the same as in your practice information sheet, and they're kind of reflecting one another. And that your practice is actually collecting the emergency contact person for patients, which is different from the next of kin. So this is the person that the patient would like to be contacted in case of an emergency. So that should be included if you're using a new patient form, registration form. That should be one of the things that is being routinely asked. If we take a closer look, as I said, at the medical records, we call the health summaries, there's a requirement to have at least 90% of your active records need to have had allergies recorded. By that we mean that the allergy section needs to have been marked as either, if the patient has an allergy, the allergy has to be entered, or if they don't have an allergy, then you have to select the no known allergy option. But there has to be something recorded in there. And it has to be for at least 90% of the active records. Again, they're just usually going to have a look at a random sample, and that's what they would be expecting, they would be finding. When we talk about active records, we are talking about patients who have visited the practice at least 3 times in the last 2 years. The other thing is you need at least 75% of your current patients need to have a comprehensive health summary. So when we say a current health summary, what we're talking about is the health summary or their patient file needs to include things like adverse drug reactions, obviously, any allergies or any issues from that. Their current medicine list. So many times I've had clinics where the patient file has been pulled up as sort of inadequate because there's a lot of old medications or old scripts that were written 3, 4, 5 years ago, and they're just sitting there inactive. So make sure that, again, even if it's just in the lead up, but ideally routinely, that your GPs are constantly clearing that list and removing any medications that are not currently that the patient's not currently taking. Okay. Then also obviously current health problems, so their past health history, any health risk factors, so their smoking or alcohol intake, their immunizations, and any relevant family or social history. So a lot of clinics, again, will have the nurse see the patient beforehand to make sure that everything is up to date, and then they can go in and see the GP for their regular consultation. This is a great opportunity now that we're all mindful of meeting our targets for our shared health summary uploads. If we've just done an update to make sure that the patient file is reflecting what's currently happening, this is a perfect opportunity if we've got a patient who has a My Health record to do a shared health summary upload, because we know that it's going to be quite relevant. Okay, in terms of the consultation notes, so again, this is what the GPs are writing in. The consultations notes, what the surveyors would be expecting to find is that there's evidence of consultations that happen outside the normal opening hours. So this could either be home or other type of visits, like residential aged care facility visits or something like that. But there's also evidence of telephone or any other electronic communications in the file. Yeah? So notes of if the patient has called or if there's been back and forth with the patient. That there's some evidence of that in the patient file. The actual progress note entry for any given sort of interaction usually should include things like the date of consultation, which usually happens automatically with most clinical softwares, the reason for visit. It's one of the things that we do need to make sure that we add. So it's sort of easy to see at a glance when you're looking at a full history of all the different times that the patient came in, what reason or what they came in for each one of those occasions. Any clinical findings, obviously any diagnoses that were made during that consult. Management and process of review, so what's going to be the plan? Did they write a script? Did they issue a referral? Did they just give some prevention advice? What happened? Any medicines prescribed? Obviously, again, as soon as they prescribe it, usually that tends to get added. Any preventative care or referrals, and any problems raised in previous consultations. Now, one of the things, and again, I've had clinics where they've been pulled up on this, is they want to see that you're not just providing sort of acute, episodic, reactive care. They want to see that when patients have come in and there's been things to follow up, that then in subsequent visits, those things have been addressed or there's comments about those things. So they might pull up a patient and inevitably they'll find someone who's come in multiple times, and they'll go back and not just look at the last progress note entry, they'll look at, some of the previous visits to see were there any issues that needed follow-up and were those actually followed up as part of the subsequent visits. So again, I've had GPs that have been, or patient notes that have been pulled up because there wasn't a lot of evidence of that kind of continuity of care. Obviously, it's only relevant if you've got patients who are coming in on a regular basis. If you only have, a lot of one-off patients, then it's probably not that big of a deal. Another area is, making sure that you have ready on the day some examples of after-hours visits. So this could be even after-hours visits that are undertaken by another service, like a locum service, and some examples of home visits or institution visits, and some examples of that patient-doctor or practice-patient phone contact. Because it's not going to be most patients who are going to have this sort of information in their file, it's a good idea to, again, a few weeks before the visit, start collecting some of these things as they start happening, and obviously keep your staff informed or give a heads up to the GPs. Go, look, can you let me know any patients that you've done home visits recently, or any patients that if we see any locum reports coming through, let's, flag those and put them aside so that we can demonstrate those at the time of the accreditation visit. Now, in terms of follow-up of tests and test results, and this is specifically usually with pathology results and imaging results or investigation reports, there needs to be evidence that when your practice receives any of these test results, that they're reviewed by a GP and that they're signed, or the electronic equivalent. So the electronic equivalent would be when they're marking them as, no action, or return urgently, or just make an appointment, or one of those, and that they're acted upon in a timely manner, and that you actually have a documented, so a written policy about the system or how you go about following up and recalling patients with clinically significant results. So the most common thing that you'll find, or the most common approach, is, again, this is looking at the clinically significant ones. So when we've had an abnormal test result come back, the most common approach would be 3 contact attempts. That could be, phone call, SMS, or whatever it is. And then the final attempt be a register post. So that's not the required, it's just what's sort of agreed as one of the most robust ways of following these patients up. So at least 3 attempts, final attempt being a register post. Again, this is mainly an issue for abnormal pathology results and people that we need to bring back in. You wouldn't necessarily have to follow this process for preventative things like just standard immunizations or routine pap smears or health assessments and things like that. Okay, this is only for abnormal test results. Some of the other documentation that they'll want to check that you actually have in place will be things like the registrations, the current registrations of your clinicians or your GPs and your nurses. And if you're employing, or if your allied health providers are not acting separately, if they're part, and when I say acting separately, is a lot of clinics will hire or lease some rooms to allied health, but aside from that, the allied health pretty much practices as a completely independent practitioner. In that instance, you don't really have to show anything, but if your allied health practitioner is actually part of, a contractor or something like that, then you should really have copies of their registration as well. You also need to be able to demonstrate the current CPD activity statement for all your doctors and your nurses with all their CPD points, and certificates for some education for your admin staff. So this can be in-house education or external education, so it's just evidence of some training that we're doing for our admin staff. CPR certificates, again, for everybody. Usually what clinics will often do is they'll just get the CPR service to come to the practice and they'll update everybody at the same time. And then you also need to have an induction program for new staff, including new GPs and new nurses or admin staff, that goes through everything, through from infection control through to how we do things at the clinic, what the different expectations are. We will be including as part of the resources what we call the staff training sheets. The staff training sheets, that template that you'll be able to access once we publish this, actually has an induction template at the front as well, so that can sort of double up. The other thing that they'll want to look at is your job descriptions and your role or position statements for all staff, and the immunization status for all staff. So what this means is that with immunization, all your staff should be offered immunization as they join the practice. They don't actually have to, they can refuse, but that has to be documented. So it's important that you have actually records of what different staff members are immunized or protected against, obviously because of the risk of exposure working in a clinical setting, and obviously where there might be sharps and things like that. The other thing that they'll again look at, and this is another area that gets a lot of practices, is evidence of meetings, either staff meetings, or actually not either, staff meetings and clinical meetings. So you have to have regular staff meetings and regular clinical meetings where you're able to discuss different things that affect the practice. And the best way to have evidence of that is either if you've been, printing out a basic agenda, or if you have minutes. Most clinics will just have agendas of what those meetings are going to be, what the focus is going to be for those meetings. The other one is after-hours arrangements or rosters, if applicable. So what are your after-hours arrangements, and how do patients know what to do when your practice is closed? So once you shut the doors, what happens? Is there a locum service? What's in place? Then also they want to have a look at the contract for disposal of sharps and biohazardous waste, as well as confidential waste, unless you're doing your own shredding in-house. But you still will need to show who's getting rid of the biohazardous waste. Then there's also vaccine fridge cold chain audit. So with your vaccine fridge, they're going to want to see that you're actually doing your daily temperature checks with your vaccine fridge, and that there's also been an independent or additional audit, which is usually in the form of a data logging. So the data logger is the device that helps you monitor the temperature of the fridge for, usually you'd put it for a week's time, and it tends to do a reading every 5 minutes. So what it does, it maps what the behavior of the fridge is in terms of the temperature over time. So usually you'd have a data logging of your fridge for at least 1 week. And there's also an audit audit checklist that is available in the Strive for 5 guidelines. So the Strive for 5 guidelines are the cold chain or vaccine storage guidelines, and they actually include an audit of, sort of like a checklist of things to go through to make sure that your fridge and your processes are adequate. And it's actually one of the appendices at the back. The other thing that tends to get practices is the schedule of maintenance of key equipment. So you actually need to have, and again, there's templates for this, but you need to have a master schedule of what equipment needs to be serviced or needs changes done to it at what frequency. For example, you might have there that, the vaccine fridge, we need to check the temperature every day, but we also have a data logging that needs to be done, once a week or once a month at least, or once a year, whatever it is. Then you might have also the scales and the blood pressure machines, like they're going to be calibrated. We're going to have an external calibrator come in and have a look at them once a year or whatever it is. So it's your kind of master plan or master schedule of all the different equipment and when things will need to be looked at. A lot of it is batteries, so keep making sure that things that use batteries, that we actually have that schedule to check and change those batteries on a regular basis, as opposed to just waiting for it to stop functioning. The other thing is a schedule for routine cleaning. So this is not just your after hours cleaning where, you might have a contractor come in after hours and clean the practice. This is what kind of cleaning happens during the practice opening hours. So what's seen as best practice is you would have a system where you'd have, usually either admin or clinical staff do a disinfecting of the surfaces, of the key surfaces, and sometimes some areas of the waiting room at least once or twice during the day. So a lot of times it'll be at lunchtime, for example, when there's a changeover of GPs and things are a little bit quiet. Then you have a staff member who goes through with a spray bottle of Sonidet or Clinidet, whatever your clinical detergent is, and just sprays or disinfects, or so does some basic maintenance and cleaning of the practice. And then sometimes you'll have clinics who also do it at the end of the day. So whoever closes the practice is in charge of making sure that they do a final disinfecting of the surfaces. So again, this should be formalized in a little bit of a schedule, and every staff member should know how that works. So is it going to be, it's always the same person who does it, or is it going to be, look, whoever goes on lunch first, when you come back from lunch, that's your job, or whatever it is, yeah? Or whoever opens the practice, whoever closes the practice. Another thing is the safe and quality use of medicines. So I've talked a little bit about this concept that patient records must have a current medicines list. So the medications that are listed in the patient file need to be the ones that they're currently taking, and anything that's expired or no longer relevant needs to be removed and sort of deactivated from or deleted from that screen. All medicines and consumables need to be obviously stored and handled according to manufacturer direction, but most importantly, everything needs to be within expiry date. So one of the big activities that we need to do, we should be doing on a regular basis, but a lot of clinics kind of leave it until accreditation time to do, is checking that everything, include all the drug samples that we may have at the practice, all of the disposables that we have at the practice, all of that has expiry dates. We need to check that all of that is within expiry date, that nothing has expired and we just are keeping it there, collecting dust. So one of the tips or tricks that some clinics use is what we call the color dot system or the color sticker system. And the way this works is you would allocate different colors to different years. So for example, you say we'll use blue stickers for things that expire in 2016. So 2016, the year will be blue, and so what we'll do is we'll put on that colored sticker, we'll put the number of the month. So if we have a drug sample that expires July 2016, it's going to be a blue sticker with a 7 for July in that blue sticker. So if we have, then we say for anything that expires in 2017, we'll say that that's going to be the color orange. So we'll have orange stickers, and then again we'll put the month of the corresponding sort of expiry date on that. So if I open up my cupboard once a month or once a fortnight or however often I'm doing my stock check, it'll be very easy to at a glance see, I know that all the orange stickers are going to be fine. Anything maybe purple is going to be 2018. Again, I know all of that are going to be fine. The only ones that I need to focus on are my blue stickers because they're the 2016 ones. And if we're in October, then fine, I need to make sure that anything that's 10 or lower I'm disposing of. Anything that's above that, I'm going to be fine. So hopefully that makes sense. So it's the color dot system, very popular. And again, all you need to get is it's a series of colored stickers and create your little legend or chart that you post next to your, usually on the wall of that stock cupboard with the legend of what color corresponds to what year. So it's just a relatively It can take a little bit of time to set up when you get a package of things or supplies and you have to kind of put all the stickers, but then it saves a lot of time because it's a lot easier to at a glance see them than having to pick up every single box and try and read what the expiry date is. And with that, they're actually going to be looking at things that you wouldn't even expect. Like everything has an expiry date. So your gloves, your syringes, your clinical detergent, all of that has expiry dates. And a lot of clinics get caught up because they think that it's just going to be the drug samples, and then all of a sudden, they've had sutures that have been there for the past 20 years and no one's looked at them. So just make sure that you do a very thorough check of everything. Now the other area is sterilizing. So if your practice is still doing sterilizing in-house, then they will look at this in a fair bit of detail. They will ask you to walk them through. So whoever the staff member is who does the sterilizing, they will ask them to show them how they do the pre-cleaning of the instruments, how they do the packaging of those instruments, how they put them in the sterilizer, how they, finish up and write it in the logbook. So they will actually ask for a demonstration of every single step. Again, I've had clinics that have been caught as not very prepared with this area. So if you are sterilizing, make sure that you've got that system down pat. They're also going to want to have a look at your sterilizer machine calibration. So it needs to be calibrated, and as part of the calibration and maintenance, they will also issue you information about what's the hardest pack to sterilize. So usually that means how many instruments, what's the maximum number of instruments that you can sterilize in any particular pack to make sure that they're actually getting adequately sterilized. So for example, if your hardest pack to sterilize was 3 instruments in a bag, then you should not be putting more than 3 instruments in any single bag, because there's no guarantee then that those are being sterilized thoroughly. So again, this is something that will come up and that you can discuss with whoever's doing your sterilization machine calibration and maintenance, because that's one of the tests that they'll run. The other area is the patient feedback. Now with the patient feedback, there's several companies, and we'll have the link of the RACGP page where they feature the different companies that have been approved to run the patient feedback. And this is what I would actually personally recommend, and what I tend to do is you just go with one of those companies, you shop around for the best quote for your clinic, and then again, like there's different versions. Some of them offer it online, some of them offer it hard copy, so you can just give it to your patients, they fill it out, and then they get sent back to that company, and they're the ones who actually compile all the results and give you a nice, neat little report at the end with your results. There is another version or another way to do it, and that's if you as a practice want to create your own questionnaire. This is definitely more involved than just using a third-party provider, because then it's not just about an amount of writing any kind of questionnaire. You have to write that questionnaire in line with all the requirements from RACGP that needs to be submitted to RACGP, and there's a lot of liaising back and forth for that to happen. So usually the easiest approach is to get one of the companies that are approved and run it through them. The other couple of things, which are again sort of like, it's almost like additional bits of documentation that you need to make sure that you have. One of them is a computer security checklist, and there's a resource for this that's provided by the RACGP. And there's also a disaster contingency and business continuity plan. So what's the plan, or what would you do in the event of, say, a fire or a flood affecting your practice, and then you needing to sort of recover that. Obviously, it'll talk about backups and alternative ways of, say, seeing patients or ensuring that patient continuity of care. The other thing is going to be list of improvements that the clinic has had in the last 3 years. So it's a good idea if you've done any changes to your processes. If you've some clinics go, we now offer online appointments, we now have a website, we now have the smart recalls, we've added more seats to the waiting room. So it can be anything from things that you've done process wise, or new features that you offer to your patients, or facility changes, or even new equipment that you've obtained, or equipment that you've upgraded. The other one is making sure that you have evidence of improvements that you've made to prevent slips or mistakes in clinical practice. So there's a thing called a near misses or slips register. This is different from an incident report. So we write an incident report when something happens. So there's an adverse event that has happened, or say someone falls in the practice, or someone's got a needle stick injury. That requires an incident report. Yeah, but before that, we have what's called a near miss or a slip kind of register. So this can be, again, electronic, or it can be a hard copy where you keep track of near misses. So this could be things like, say we've got 2 patients with the same name and we opened the wrong patient file, and the GP ended up writing the script for the wrong patient, or we booked the wrong patient in, or we printed the pathology slip for the wrong person, or we had an aggressive patient come through the reception and nothing actually happened, like it was managed, but it could have led to a bad outcome. So again, the idea of the near misses register is an opportunity to document things that went, oh, actually that could have resulted in something bad. It didn't, but it's a good idea to document that and then talk about it. You can use it as part of your staff meetings. So discuss it as part of your staff meetings to make sure that obviously if there's any training or changes that need to be made in the practice to prevent that from happening, then that occurs. Or also just to make sure that it doesn't happen again, or if it happens again, how are we going to manage it? So just make sure that you have also, that near misses register. In terms of practice equipment, we have things like you need to have timely access to spirometer and ECG machine, and make sure obviously that you maintain your equipment, as I said, based on that schedule of maintenance. The other thing that sometimes gets clinics, or not so much anymore, is you need to have at least one height adjustable bed in the practice. Not every consulting room, but at least one of them needs to have a height adjustable bed. So with a spirometer and ECG machine, it's timely access to them, so you don't have to have them in the clinic. It is a good idea to have them in the clinic if you can, and a lot of the times you can actually get these supplied to you from pathology companies. Not always, but it depends on the relationship that you have with your pathology company. Sometimes they won't give them to you, but they'll just sort of lease them to you for free, essentially. If you're going to be sending them the ECG for interpretation, there's an added benefit there for them. So in terms of policy, so the actual written policies that your surveyors are going to want to have a look at, the key things that you have to make sure that you have is what's your policy on home visits, how do you do your review of results and any letters or correspondence received by the practice, what's your cold chain, so that's your vaccine storage policy, your infection control policy, handover of patients, so how do we actually communicate to other providers when we're transferring care, either within the practice or outside of the practice, or if providers in the practice are going on leave and we need to sort of hand over those patients to another provider to look after them in the meantime. How does that happen? So you need to have that written policy around that. Practice feedback, again, how does it, not just from your feedback, your evaluation survey that you do, but also how does the clinic get feedback from patients about their experience or what things your practice could be doing differently. Also adverse events, so what's your policy on dealing with adverse events, the policy on routine cleaning that I was talking about, and the 3 patient identifiers. So what is this 3 patient identifiers? The 3 patient identifier came from an attempt to try and prevent that same issue that I was just talking about, where you have 2 patients with similar or same name, and then all of a sudden we're writing scripts or treating the wrong patient or opening up the wrong patient file or providing the wrong treatment to the person just because they have similar names. So the idea was to, before every important encounter, we would use 3 ways of identifying that we've actually got the right patient in front of us. So this would be applied when we're making appointments, when we're writing prescriptions, writing referrals, giving results, or entering any correspondence into a patient file. So the most common things would be the patient name, date of birth, and address. That's not limited to those, like there's other indicators. Medicare number is not an adequate indicator. So an example of this would be if someone's calling your practice, they're making an appointment over the phone. To make sure that you've got the right patient, your receptionist would ask, okay, can you tell me your full name and just confirm your date of birth? Fantastic. And what's your address? Or you can say, are you still at, and have the full address. So the idea is to then make sure that, you've got the right patient in front of you. In theory, we should be doing that not just when we're making the appointment, but then, if we bring somebody into the consulting room and we're opening up the patient file, we confirm it then and there as well. It sounds like a lot of double up, but as you can imagine, if it can prevent some very serious adverse consequences. This has been a huge thing also in hospitals, as you can imagine, because you don't want to run that risk of multiple patients getting the wrong treatment just because they have similar names. The other thing that I wanted to talk about is in terms of the infection control. There's the process, having the process for routine cleaning of the practice, the immunization of staff, which I've said already is not mandatory that they have to have the vaccine, but it is mandatory that you actually keep track of, whether or not they're vaccinated. And if they're refusing, that's fine. You just have to have documentation of the fact that they're refusing. And also, you have to be able to demonstrate how you are educating patients about respiratory etiquette, so coughing etiquette, and hand hygiene. Obviously, the easiest way to do this is usually by having posters, either in the waiting room or in the bathroom, that teach patients about, hand hygiene, cover your mouth when you're coughing, and again, I'll have links for that as part of the blog post once we post the recording of this. In terms of the resources, the key things that you need to make sure that you have that are going to make your life a lot easier. One is obviously a good policy and procedure manual. There's several templates out there that are very comprehensive, and all you really have to do is essentially just customize the bits that apply to your practice. I will have a link to a triage guide. So triage is your way of assessing urgency for patients, and usually, again, this is an area where your staff should be trained. I'm actually going to include a link to a free online training of a triage training that you can then just sign up your staff members to do and kind of meet that component. So usually with triage, what tends to happen is there's a wall chart that is a quick reference that anyone who's on the phone or and the reception can have a look at and assess, okay, this needs to go to hospital, or this can be treated today, or this can wait to the next available appointment. But then there's also, as accompanying that, is the staff training sheets. So we do have in that staff training sheets set that I was talking about, there is some training on triage, so some basic information about triage, and there's also things on how to deal with interpreters for patients who speak a different language, cold chain, infection control, so a lot of those different things, as well as that induction checklist that you would use for all the new staff. So I'll also have there's sort of like a sheet that I call the kind of top checklist to be ready for accreditation, which essentially is like a summary of all the things that I've talked about today. So again, it's a really good checklist to make sure that you go through to make sure that you're ready before your visit. So all of these resources are going to be ready on the post once we publish this webinar. And that is it for today's presentation.